السلام عليكم للجميع، صباح الخير أو مساء الخير وين ما كنتوا. اليوم أنا اسمي، خليني أعمل شوية introduction لنفسي. اسمي أسامة عمرو، أنا American Board Certified in OBGYN و American Board Certified in Minimally Invasive Gynecology Surgery. واليوم راح أحكي يمكن موضوع مختلف عن اللي المين stream of subjects that you guys discuss usually in ground rounds. بس أنا بعتقد إنه موضوع مهم كتير وممكن إنه تتعاملوا معاه بشكل دائم ككريتيكال كير فيلو. اليوم رح نحكي عن البريكلامسيا. رح أبدأ بسرعة بحالة سريعة عن البريكلامسيا وبعدين رح نتناقش في الموضوع. والcase is 27 years old female, gravida 1 para 0. Gravida 1 means this is her first pregnancy. She's at 37 weeks. Pregnancy was relatively uncomplicated, was seen in the clinic a week before presentation to the emergency department with a blood pressure of 138/85. She was also complaining of headaches, but there was no visual changes or epigastric pain. At the clinic, they ordered a CBC, CMP, 24-hour protein, and everything came back with a normal limit. She presented a week after to the emergency department with an elevated blood pressure of 220/110. She had a grand mal seizure, fetal heart tones of 90s, and she also had a vaginal bleeding. The decision by the emergency physician at that time was to proceed with IV labetalol 20 milligrams IV. She was started on magnesium sulfate, 6 milligram loading dose, and then 2 milligrams an hour. Anesthesia was consulted, and the plan was to proceed with a crash stat cesarean section. During the C-section, it was evident that there was a placental abruption, which can explain the bleeding that she had at presentation. Abgars of the baby were 2 at 1 minute and 6 at 5 minutes, and the fetus was evaluated by the NICU team. Patient blood pressure improved over hospital stay, and she was started on labetalol PO, 200 milligrams PO BID. Labs were normalizing. There was no evidence of HELP syndrome. Continued on max sulfate for 24 hours after delivery. There was no neurological manifestation, and she was discharged home in stable condition. ما بعرف إذا حدا عنده أي سؤال. يمكن الموضوع زي ما حكيت شوي بيختلف عن المين ستريم. إذا حدا ما فهم بعض الترمينولوجي اللي استخدمناها ممكن يسألني. بما أنه ما في حدا بيسأل معناها أنا راح أعتبر أنه الأمور واضحة إن شاء الله. What is preeclampsia? Preeclampsia is a systolic blood pressure 140 and the diastolic blood pressure, or a diastolic blood pressure more than 90. So a blood pressure that is more than 140/90 on 2 occasions. Or if the systolic blood pressure was 160 and the diastolic blood pressure was more than 110. So we have to have 2 readings to diagnose preeclampsia if it's mild preeclampsia. And I think the old terminology was divided into mild preeclampsia and severe preeclampsia. With mild preeclampsia, we need to have a blood pressure more than 140/90 on 2 occasions. With severe preeclampsia, blood pressure should be more than 100 at or more than 160/110. We used to say that preeclampsia is always associated with proteinuria, and this terminology changed recently. Anyway, in order for us to diagnose preeclampsia or typical preeclampsia, we have to have a proteinuria more than 300 milligrams in 24 hours. Or if you have a protein to creatinine ratio of 0.3 or higher. And if you don't, or you can't do a 24-hour protein, sometimes we depend on urine dipstick protein, and it has to be at least +1 or more. Preeclampsia with severe features, or what we called before severe preeclampsia, consists of blood pressure of more than 160/110 in 2 occasions at least 4 hours apart. or if you have some kind of impaired hepatic function and elevated AST and ALT, if you have severe persistent upper epigastric or upper right quadrant pain, or if you start seeing more of progressive renal insufficiency. If the patient starts having new onset cerebral or visual disturbance, pulmonary edema, or thrombocytopenia. So basically, it's an elevated blood pressure with some kind of end organ damage, looking into hepatic function, renal function, cerebral function, pulmonary edema, or even thrombocytopenia. A new onset hypertension without proteinuria can be still considered as preeclampsia, especially if it has the following findings: a platelet count of less than 100,000, serum creatinine level above 1.1, or doubling of the serum creatinine in the absence of other renal disease. If the liver function test is abnormal at least twice the higher limit, and then if there's any pulmonary edema, cerebral or visual symptoms. Eclampsia, on the other hand, is defined as seizures that cannot be explained by other causes in women with preeclampsia. So if you have a patient who have a grand mal seizure with a history of preeclampsia, we assume that this is a seizure disorder unless there's another cause for it, or if there's another history of a seizure disorder or any other disorder that is related to seizure in the patient. HELP syndrome, on the other hand, include hemolysis, elevated liver enzymes, and low platelets. Now, there's many risk factors for preeclampsia, including nulliparity, multifetal gestation, preeclampsia, and previous pregnancy. If the patient is chronic hypertension, if she has a pregestational diabetes, if she's diabetic, if she had an SLE, or, if she's maternal age is more than 35, can have a history of kidney disease, if she had an IVF before, all of these risk factors can be, a risk factor for a future pregnancy or current pregnancy for preeclampsia. Preeclampsia without severe features or without end organ damage could be asymptomatic. Preeclampsia, if you look at it and you look at every aspect of spectrum of disease that it can cause, honestly, you can consult everyone in the hospital. So if they have high uric acid, you'll consult urology or nephrology. If they have low platelets, you'll consult hematology. If they have seizures, you'll consult neurology. So if you don't understand preeclampsia and you understand the spectrum of symptoms and signs, it will be very hard to manage the patient, and you will have it so difficult to understand all these symptoms that the patient is having. So it's very important for us maybe today to discuss basically what is preeclampsia in very simple details, so everyone in this lecture will understand at least how's the progress of this disease. So diagnosis of preeclampsia is not straightforward. Preeclampsia can present with many end organ damage, as we discussed before, including headaches, visual disturbance, altered mental status, even blindness, edema, epigastric pain, weakness, and seizures. All women with a new onset hypertension should have the following testing: CBC, liver function test, serum creatinine levels, uric acid, and if you can do a 24-hour protein, that would be great. Additional studies, if you suspect that we're dealing with HELP syndrome, you should do peripheral blood smear, serum LDH, and indirect bilirubin. Do we have to do really a CT scan if you have a suspicion of eclampsia and preeclampsia? Not really, unless you have the following indication, like sudden severe headache, focal neurologic deficit, seizures, and atypical presentation of eclampsia. Other tests that we can do is ultrasound to make sure the baby's doing okay. You can do umbilical artery Doppler ultrasound, and you can also evaluate the growth of the baby. And you can also put the baby on the monitor for non-stress test and other abnormalities. Treatment, and this is very important, and you may face this as a critical care fellow or an internal medicine resident. The treatment for preeclampsia is delivery, and not the delivery of the baby, the delivery of the placenta. And we're going to talk about that in a second. So the treatment of preeclampsia is not blood pressure medications. The treatment of preeclampsia is the delivery of the placenta. And why do we say placenta? Because the origin of the disease is the placenta. See, at the beginning of the baby formation, when the placenta or the fertilized egg attached to the uterine wall, a cascade of event happens to create a normal placenta. And in preeclampsia, this cascade of event fail. So the origin of the problem is the placenta, and the delivery, and the only cure for preeclampsia is the delivery of the placenta. I want to repeat that a lot because there's a lot of misconception that preeclampsia is high blood pressure. It's not. Preeclampsia is diagnosed by looking at the blood pressure, but in reality, it's a disease of the placenta, and the only treatment is a removal of the placenta. So what is the management of preeclampsia? If a patient is having mild preeclampsia, usually we wait up to 37 weeks to deliver the patient. If the patient is having severe preeclampsia, it can be delivered anytime based on the baby maturity. So it's like a triad. So you have to look at the maternal health, you look at the baby health, and you look at gestational age. At any time the baby is not doing okay, and the baby can survive, we deliver. At any time the mother is not doing okay, and the mother can survive, we deliver. At any time we reach maturity, we go ahead and deliver. So it's always this kind of dynamics between the three aspect of this triad: the mother, the baby, and gestational age. Patient with severe gestational, preeclampsia with severe features, usually we consider deliver them at 34 weeks. And the reason is the chances or the percentage of fetal death at 34 weeks due to immaturity is less than 1%. So it's more comfortable for us to proceed with the delivery at 34 weeks in patient with severe preeclampsia. So in patient with preeclampsia, what do we do? Let's say the patient comes to the emergency department with seizures, and you were covering the ICU that night, and they call you for a consult. You do the same thing you do with anything else. You just make sure that the ABC are checked. You have to control blood pressure. So the most important thing for us is to control blood pressure. And one of the most annoying things that sometimes the ER called me or medicine called me for is that what kind of blood pressure medication we use to be safe. And at that point, it doesn't really matter. You just have to control the blood pressure, because if you don't control the blood pressure, we'll have neurological damage and we'll have fetal damage at the same time. We prefer labetalol, but I'm not going to wait and delay the treatment just because I'm waiting for IV labetalol or the nurse to bring me live labetalol to give the patient. So if you have anything in hand and you're trying to save the mother life, and you feel like there's a lot of bleeding, and you think there's an abruption, and you also think that the mother is trying to be unconscious for any reason, I think the best thing to do is to control the blood pressure by any means. And then after that, we can always start with magnesium sulfate. We give them 4 grams or 6 gram loading dose over 10 minutes. And then we'll start giving 1 gram or 2 grams every hour. We keep doing that till we make sure that we control eclampsia very well. And in cases of refractory seizures, you can always use other medication like lorazepam. So acute treatment of severe hypertension in pregnancy, it's usually recommended if the systolic more than 160 and the diastolic more than 110. And why 110? Or actually, sometimes there's some guidelines about 105, because the curve of stroke go up quickly after or when the diastolic blood pressure is more than 105 and 110. So we are trying to reduce the chance of neurological damage by controlling the blood pressure. And as I said before, you can control blood pressure by many medication, including labetalol, hydralazine, Procardia. These are the most used medication in preeclampsia and eclampsia, and it can really help the patient a lot. And there's a specific guidelines about how to use these medication. So when you give, for example, labetalol, you wait 10 minutes, and if there is no improvement, you give them again up to a limit, and so on. Now, Lasix should be avoided, and I'm going to talk about it in a second. Why is that? And, aggressive volume resuscitation may lead to pulmonary edema. Patients should be fluid restricted when possible, at least until the period of postpartum diuresis. CVP, or pulmonary artery pressure, only used in critical cases. And CVP of 5 milligrams, 5 millimeter mercury in women with no heart disease indicates sufficient intravascular volume. And you should be just very conservative with giving fluids, and I'll talk about it in a second. In postpartum period, patient usually will have diuresis, and then we continue the magnesium sulfate for at least 24 hours. You have to make sure that you have a liver function test and platelet count documented, trending down before discharge in case of severe preeclampsia or HELLP syndrome. As we said before, in postpartum period, you can use nifedipine or Procardia or labetalol. You have to make sure that you are discharging patient on medications, blood pressure medication. Preeclampsia can continue up to 12 weeks after delivery. And you may also have some kind of, eclampsia can happen up to 6 weeks. Now, usually it doesn't. Usually if eclampsia would happen, it would happen within 72 hours. After 72 hours, you have to look for other causes like a seizure disorder, AV malformation, other stuff that can cause eclampsia. But case reports show that eclampsia still could happen up to 6 weeks postpartum. So I think this is conclude my slides. I just want to talk about it like freely for maybe 5-10 minutes, and then I'll give you the chance to ask any questions you guys feel like you want to ask. So as I said before, there's main points of preeclampsia that I always like even to teach my medical student about them, because I feel like there's needs some kind of education about preeclampsia, that it's not just a disease that we control with blood pressure. So as I said before, a fertilized egg will go all the way in a journey to the uterine wall. It will attach to the uterine wall. There's something called spiral arterioles that usually with pregnancy, it will be like a lead, so there will be no resistance in it. It will change, the placenta will change that. In preeclampsia, this process failed to happen. And because of that, a lot of hormones in the body change. So the thromboxane A2 will be less, prostacyclin thromboxane A2 will increase, prostacyclin will decrease. That can cause vasoconstrictions and high blood pressure. Beside the vasoconstriction, fluid will leak from intravascular to extravascular. So that's why we don't give Lasix, we don't give diuretics, because in reality, the patient is dehydrated. Even though all the fluids are there, but it's not intravascular, it's extravascular. And this applies to everywhere in the body. So they'll have cerebral edema because of the fluid shifting. They will have liver pain because the liver will enlarge and it's causing pressure on glycine capsule, and that's why they have epigastric pain. They'll have oliguria because the fluids are not intravascular, they're extravascular because of permeability. So one of the things that we use to know that the disease is reversing is by having diuresis. If you start seeing a lot of urine comes out through the Foley in patient postpartum, you know the disease is reversing, and it's a good thing. It means that the fluids from extravascular space is going intravascular through the kidneys outside. And we can explain a lot of symptoms based on this physiology and dynamics. As I said before, all these symptoms, including headache, visual changes, epigastric pain, oliguria, kidney damage, all of that can be explained by the shifting fluids between intravascular, extravascular, vasoconstriction, increased permeability, and so on. Magnesium sulfate, as you know, is used 24 hours after the delivery, and that to do some kind of neuroprotection and to reduce the chance of eclampsia. A lot of doctors, though, if they see a lot of urine comes out and they are sure that the preeclampsia is reversing, sometimes they take the Foley out and they stop magnesium sulfate. But for argument's sake, we'd like to keep it for 24 hours after delivery. And you have to always make sure that the max sulfate levels are within therapeutic range. So if the lab called you and they said, "Oh my goodness, doctor, this and that, potassium level is 5.2, it's critical value, and you know what's going on with the patient," lab doesn't know what you're doing. So we are giving them magnesium sulfate to make it higher. So that's normal. The only time that is not normal when they start losing reflexes, and at that time we know that we're doing hypermagnesemia, and you get concerned about respiratory failure and so on. So there's a lot of aspects of preeclampsia that you should be careful about dealing with. Also, you have to always make sure that when you're dealing with preeclampsia, you will look at the whole picture. Again, you can have multiple symptoms and signs, and if you're going to consult everyone in the hospital, you'll have a team of 15 doctors, but in reality, the only doctor who should be able to take care of it is either the critical care with OB or the OB with maternal fetal medicine.
شكرا لكم لأنكم أخذتم وقت حتى يعني تحضروا الجراوند راوند، وبتمنى أنكم استفدتوا.